Bueno, el doctor Richard Allen es el presidente actual de ASOPers y él amablemente había aceptado nuestra invitación para venir a nuestro congreso. Desafortunadamente, de último minuto ya no pudo venir, pero nos hizo el favor de grabar su plática y mandarla. Así que Richard, thank you so much. We're sorry you're not here. We miss you, but we're looking forward to having you in our next meeting. Gracias.
So sorry that I can't be there with you guys. Truly sorry. Wish I were there. But anyway, Jorge has put on a great meeting. And what I'd like to talk about is obesity and oculoplastic surgery and how this affects what we do. And that means not just what we do, but also how we prepare for it, and then what potentially happens after our surgery, as well as some of the things that are associated with obesity. I have no financial disclosures. So just to start off, we ought to sort of define what overweight means and what obese means. If you look at the strict definitions of these, an overweight individual is someone who has a BMI greater than or equal to 25 kilograms per meter squared, whereas an obese individual is someone who has a BMI greater than or equal to 30 kilograms per meter squared. We all know that obesity is a problem, especially in the Western world, especially in the United States. In the United States, the prevalence is almost 43%. That is amazing when you think about it. And this costs us a lot of money just because of all of the associated health conditions that we see with obesity. And so, if we look at the countries that have the biggest burden with regards to obesity and healthcare, USA wins. And that's not something that we're proud of, but it's just a fact, unfortunately. With regards to general medicine associations with obesity, I mean, basically you name it. There are just everything that you can imagine is going to be associated with obesity: diabetes, hypertension, sleep apnea, heart disease, cancer, et cetera, et cetera, et cetera. So, this is not something that we should take lightly, in the sense that even though we have this huge incidence and prevalence of obesity, it's something that truly affects our daily clinic as well as our daily surgery. And that's what I'd like to talk about today. So, how does this affect us? Well, there are preoperative issues, there are intraoperative issues, there's postoperative issues, and then there's a number of conditions that we all know about that are associated with obesity. So let's just talk about preoperative considerations. First and foremost, hypertension. If a patient has hypertension and they come to your preoperative area, it's not uncommon for me to have patients be canceled if their hypertension is out of control. But this also puts them at risk of having problems intraoperatively. Coronary artery disease, again, something that we need to be careful of, because if we have patients who have coronary artery disease, that puts the patient at risk for having issues during the surgery. Anytime we put a patient through surgery, we're going to stress their body. And when we stress their body, if they have coronary artery disease, that puts them at risk. The obese patients also have a greater incidence of arrhythmias. And so, with regards to preoperative cardiopulmonary evaluation, 1/3 of obese patients develop changes that lead to cardiomyopathy. So, if you have that obese patient, you have to keep that in the back of your mind. Now, with regards to respiratory complications, there's problems with regards to airway patency during intubation. There's respiratory depression during the surgery, decreased chest wall compliance, decreased compliance with of the lung parenchyma. And this is all made worse when the patient lays supine. So, truly, when you have that obese patient, you should consider placing that patient in reverse Trendelenburg position, because this will increase the ease of intubation, and it will also improve functional residual capacity. So, we know what the different positions are. So, It's not great to have a patient in reverse Trendelenburg because their head is pretty high. And, if you can't bring the bed down, that's going to make you stand up for the surgery. So, as oculoplastic surgeons and ophthalmologists, we like to sit down during surgery. But when you place that patient in reverse Trendelenburg position, that's going to that's going to make us stand up, which a lot of us don't like to do. So, things to think about when you see that obese patient. Intraoperatively, what do we worry about? Well, there's a weight limit to surgical beds, of about 450 pounds. Not only that, but my ASC actually has a BMI limit. So if the patient is over a particular BMI, they won't even consider doing them in the ambulatory surgical center. They'll tell me to take the patient to the hospital. Again, during the surgery, consider leaving that patient in reverse Trendelenburg. The anesthesiologist will make it a little easier for them to intubate if they have them in reverse Trendelenburg, but also, with regards to, especially if the patient is put to sleep, they do a little better if they're in reverse Trendelenburg position. And then always remember to pad these patients. I mean, they are heavy, and so you're going to get peripheral neuropathies if you don't pad them. And, they can get pressure ulcers as well as tissue ischemia. So keep that in mind, especially if you have a prolonged surgery. Bleeding risks are real in these patients. They have hypertension, which often is not controlled. They're often on anticoagulants because of their cardiac issues, and they may have an elevated heart rate. So these patients are a setup for having bleeding issues during the surgery. So keep that in mind when you take care of these patients. Be prepared. And what I mean by that is make sure that you have your good cautery, et cetera, et cetera, et cetera. Sleep apnea is one of those things that we see in obese patients. Obesity is the strongest risk factor for developing obstructive sleep apnea, and this results in increased operative complications, higher rates of transfer to the ICU, and then hypoxemia impacts wound healing. So if these patients go home and don't wear their CPAP because they've had surgery on the face, hypoxemia will impact wound healing as well as increase your risk of infection. And then we will talk about later about this correlation with floppy eyelid syndrome. So when you think about these patients, normal sleep, you should have sort of this patent airway and sleep apnea. This is blocked. And so, these patients just don't do well postoperatively. They often get sent to the ICU. I've had many anesthesiologists who basically tell me that I have to admit the patient if they have sleep apnea because they don't want them to go home and stop breathing after they've been given anesthesia. And then the other thing to remember is that opioid use can actually increase the rate of nocturnal hypoxemia. So you want to really use opioids sparingly in these obese patients because it will decrease their respiratory drive. And so, if you have that obese patient who also has sleep apnea, you give them opioids on top of that, and they go home and they don't breathe. And so really, really important to use opioids sparingly in these patients. Now, with regards to postoperative considerations, there is probably this increased risk of hematoma formation. A lot of these patients are on chronic NSAIDs just from their joint pain. I just had a case just recently, and the patient basically told me that she cannot stop her NSAID because she will have too much joint pain. So I'm sort of stuck. I have to operate on her when she's a little bit anticoagulated. But again, these are things to think about. And then with regards to wound healing, increased risk of wound infection, delayed healing, as well as wound dehiscence in these patients. I think one thing to always remember is that if you have a patient with sleep apnea, what patients do is that they sleep on their face. And so if you've done eyelid surgery on them and they're not wearing their CPAP, they go home, they sleep on their face, and they dehiss their wounds. So if you have that patient that comes in, a week after surgery, they dehiss their wounds, you ought to think about sleep apnea, because I think that that's something that we definitely see when these patients go home and basically sleep on their face. Also hyperperfusion of subcutaneous tissues can result in postoperative infections. So always something to think about, in these patients. They're at an increased risk of infection, dehiscence, et cetera, et cetera, et cetera. So, keep this in mind in your patients that are obese. A lot of these patients do undergo bariatric surgery, but then this also introduces a potential problem for us. Basically, when these patients undergo bariatric surgery, they will often have aesthetic surgery afterwards due to increased laxity of the excess skin. So, basically the recommendation is at least wait a year after the bariatric surgery to address any aesthetic concerns. And, the issue is that these patients have increased issues with blood glucose, anemia, electrolyte abnormalities, and 10% of bariatric surgery patients have arrhythmias. So even though they've had their weight loss surgery, they are still at risk for having problems. So keep that in mind. And, when we think about bariatric surgeries, there's different types. You have gastric sleeve, gastric bypass, gastric band, and then intragastric balloons. Now, the issue is that on some of these, you can get malabsorption of nutrients. So malabsorptive procedures shorten the digestive tract. And so you can have issues with fat-soluble fat-soluble vitamins, iron, macronutrients, and this can affect wound healing. So you need to make sure that these patients are optimized nutritionally before you do surgery. So what are some of the things that we do see in these patients that are obese that we take care of in oculoplastic surgery? Exophthalmos, this increase in orbital fat, probably isn't something that we necessarily see in obese patients. And what I mean by that is that we don't necessarily see an increase in fat in the orbit in these patients that are obese. However, there is this interesting correlation with Cushing's syndrome. And, in that syndrome, the body makes too much corticosteroids. And we can also see this from chronic steroid use, and patients can get exophthalmos from that. So not necessarily an obesity thing, but more due to Cushing's syndrome. Now, what about sleep apnea in the lacrimal system? Well, this is something that you really have to worry about because you can get air regurgitation from your CPAP. So you can get subcutaneous emphysema after DCR. And then if you place a Jones tube, you can get, basically air through the Jones tube into the eyelids. And so, things to think about that if you do lacrimal surgery on these patients and they're on sleep apnea, they're getting positive pressure through their nose. And in doing that, they can get subcutaneous emphysema. They can get air transfer through the Jones tube. And so we all know how this works. You have this new opening and, with positive pressure from the CPAP, you can get subcutaneous emphysema. And again, positive pressure in the nasal passages can get transfer of air into the eye. So patients can, not tolerate Jones tube placement after CPAP. And so things to think about, with regards to what you might have to do. Sometimes the patients can adjust their CPAP. They can have different fittings, but you'd rather figure this out before you do your surgery. We all know about the association of idiopathic intracranial hypertension with obesity, with regards to how this occurs, thought to be maybe occult microthrombosis impacting CSF absorption, as well as possibly increased intra-abdominal pressure impeding venous reabsorption. So, how do we treat this? Well, this is usually taken care of by the neuro-ophthalmologist and not us, but the issue is that these patients get sent to us for optic nerve sheath fenestration. So definitely one of those things that affects our practice with regards to these obese patients that have idiopathic intracranial hypertension get sent to us for optic nerve sheath fenestrations. And then we have to think about all these other things that are going to potentially cause a problem with the surgery due to their obesity, as we had discussed. Prolapse subconjunctival fat, this is freely mobile under the conjunctiva. We see this association with floppy eyelid syndrome, thyroid eye disease, as well as obesity. Sometimes it's difficult to distinguish these from a lipodermoid. For me, it's pretty straightforward in the sense that lipodermoids are not mobile and, they're not acquired. And so excision for this is usually pretty straightforward. Just make an incision through the conjunctiva, prolapse the fat forward, conservatively debulk it. I think it's just important to always remember to stay away from the lacrimal ductules as well as the rectus muscles. So patient here, bilateral subconjunctival fat prolapse. Again, usually not a mystery with regards to what this is. And here's a patient. He came in and he actually told me he wasn't terribly obese, but he actually told me, "Hey, I just lost 100 pounds over the last year." And it's not because he had cancer or any chronic disease. He actually worked hard and lost 100 pounds, but he had this fat prolapse associated with that obesity. Xanthelasma, we see these in patients that is associated with hyperlipidemia. Again, there is a correlation of hyperlipidemia with obesity. So, you're going to see these a little more often in your obese patients, but not strictly, in the sense that I've seen plenty of patients that are pretty lean who have xanthelasma. So, I usually like to incorporate these into a blepharoplasty incision. I think direct excision is pretty good. Here's patient before and then after her xanthelasma incisions. You can see her incisions along the lower lid, and then this was incorporated into her blepharoplasty incision, which you can see here. Usually works pretty well. I'm usually pretty satisfied with that procedure. Now, epiblepharon is a mechanical issue from excess, maybe excess subcutaneous fat or just redundant skin, and just sort of an anatomical issue. We see this more in Asian kids and Hispanic kids. It's really an anterior lamellar abnormality. Extra roll of skin pushes the eyelashes towards the globe, usually the lower lid, but there is sort of a component of this that we'll see in the upper lid as well. My treatment for this is usually conservative in the sense that I usually just have lubricants. I think most kids will usually grow out of this as their face grows. When do I treat this surgically? Well, if the patient has amblyopia or if they have significant photophobia. And what I mean by that are these patients that basically sit in dark rooms, and their parents will tell you that. You just ask them, do they go outside? And they'll say, no, they like to stay in a dark room all day because the light bothers them so much. So to me, that is a reason to do surgery for these patients. What I usually do, conservatively excise the skin, debulk the orbicularis. I like to disinsert the lower eyelid retractors and then incorporate them into the skin closure. So patient with epiblepharon, but then taking a step back, she's a little chunky. And a lot of times I'll have parents come in who say that, the kids have basically acquired this. And you look at the kids and, they're a little chunky, and my prescription for this is usually for them to join the cross country team, because if you're running 5 miles a day, you're not going to be able to keep that weight on. So I've had parents so ask me directly if I think that obesity is making it worse, and I tell them, yeah, I do. And so it's something that we need to take care of in these patients. Lastly, let's talk about floppy eyelid syndrome, because this is one of the things that we see a lot of. Easily to avert upper lids. The way I check this is that I have the patients look down, then I lift up on the upper eyelids to see how much I can distract them. And to me, this is part of the exam. I do this on everybody, and usually the lower eyelids are lax as well. The tarsus is rubbery, sort of unstable. What do these patients complain of? Tearing, discharge, eye irritation, especially worse in the morning. And truly, this is notoriously misdiagnosed, in the sense that I've had patients come in who have seen multiple providers who just have not pulled on their upper eyelids. And, the cause of this is really thought to be related to sleep positioning, in the sense that when you have sleep apnea, you can no longer sleep on your back, because if you do, you stop breathing. And so what do? Well, they learn to sleep way over on their side or on their stomach. And when they do this, there's this mechanical basically injury to the eyelids, and with time that stretches out the eyelid. You can almost diagnose this from the door, because these patients are obese, they have short, thick necks. You know, I always show the anesthesiologist because I say, hey, if you want to diagnose sleep apnea, just pull on their eyelids. They're always sort of amazed when I show them that. But, you know, truly years of sleeping on their face causes mechanical damage to the eyelids, and the eyelids often avert when they sleep. They get this papillary conjunctivitis as well. You know, to me, all patients with floppy eyelids get sleep studies because, you know, this is potentially fatal condition. You know, this is how patients have heart attacks in the middle of the night. You don't want to operate on these patients before treating their sleep apnea. And there is evidence that the symptoms can resolve just with proper sleep treatment of their sleep apnea. And, you know, like I said before, these patients with untreated sleep apnea have an increased risk of wound dehiscence. So always think about that. What do I usually do if they haven't had their sleep, if they're not on CPAP? I'll have them wear a Fox shield over their eye. It's also a good test for me to see if their symptoms improve. And, you know, so if they do have sleep apnea and they have eyelid surgery, I'll often have them wear Fox shields, at least for the first week, to prevent wound dehiscence. Surgical treatment, I don't attempt, like I said, to treat them prior to treating their sleep apnea. Upper and lower lid tightening, I try to preserve the tarsus. And I prefer upper lateral tarsal strip over a large wedge resection. So this guy comes in complaining of ptosis. He's sort of thick. He has a thick neck, short neck. Pull up on his upper eyelid, and you're going to diagnose him with sleep apnea as well as floppy eyelid syndrome. Another one comes in for ptosis. He has lash ptosis as well. You know, these patients have lash ptosis, and you know, pull up on his upper and lower lid, you can see how loose he is. So obesity is a big problem for us in oculoplastic surgery. It's a big problem for all of us in medicine. Has a significant effect on healthcare. And so it's always important to consider all of these potential associations so that we give the best care to these patients. Again, thank you so much for inviting me to give this talk. Jorge has done a great job. I really am sorry that I'm not there, but look forward to seeing you guys in the future. Thanks so much.